to do these procedures. So what sort of equipment do you need to do what we've been doing today? If you're going to start up your practice in submucosal endoscopy, you for sure need a decent endoscope. You must have some sort of high resolution endoscope, be that near focus, magnification, something to help you with bleeding, because really underwater also you need magnification, something that's got good bending, because often you may need to get into space. And you may think in POEM, maybe there's absolutely no need to have a good bending scope. But I do remember back in the original days of doing POEM that the scope could not, the tip of the scope could not form that really nice bend with the small wheel. And then I was having real trouble, like what I did today with burrowing into the side of the tunnel. This for sure would not be possible without a well-bending tip endoscope. So to do the stuff that's more difficult than normal, you need a high-performing instrument. And you should consider, as we said yesterday, that instrument should maybe be reserved for these procedures, or at least not stressed by standard procedures, because performing standard procedures on that scope, for example, if it's used all the time in everyday practice, and then you want to use it, maybe it's not available, and also maybe the bending or whatever is not good. So, okay, if you have that luxury, maybe you should do it. We do it with the therapeutic instruments that we have here, some of them, not all of them, but some of them. We have 2 gastroscopes, which we are using only for therapeutics. And that's the reason why they're performance. And if they're not good, in terms of bending, they're getting sent to the firm for checking. So this is the sort of level of, maybe you didn't know that, but that's the sort of level of, attention to detail. So John says he needs to leave. So John, I think, is that now that you have to go? So
Yeah,
maybe we say
I have
goodbye
to
to
go.
you.
Yeah, I have to go and do a score. I'm really sorry, David, but I
No
have to.
problem. Well, thanks so much for being present. Let's just say bye to John and acknowledge the contribution you made, and I hope you enjoyed it. We really got a lot out of you being present. So, yeah, thank you very much
Yeah,
for
well done,
being here.
guys. Yeah, bye.
Thank you.
See you later.
Bye.
See you later.
What's the role of a very good high resolution endoscope? Would have been so much different doing, or even possible to do that with a scope? Maybe, I don't know.
I can answer your question from experience, because when I started here, I was using sometimes 180 Olympus. So 180, for those of you who are too young to know, is 3 generations back from the current. So you have 180, 190, 190 HQ, and then the current EZ 1500 double scope. So these instruments are old now. Maybe when I came here, that was 4 or 5 years ago, they were already 8 years old. And it was very difficult. So the plane interpretation, even more difficult, and something which I struggle a lot with. Also screen resolution. Of course, if your screen is high resolution and your scope is poor resolution, it still doesn't help you very much. Upscaling sometimes is happening now, but still, this is a problem. So yeah, I think you're right. I did do procedures like that were extremely difficult with those old instruments. It was extremely painful and extremely nerve-wracking, and I'm very glad I don't have to do it anymore. Is my answer to that question. So is it possible? Interpretation, typically you have to guess a lot more than you do here. Does it sometimes work? Yes. It sometimes also didn't work. Is that my skill set that's improved over those years? Well, it definitely has. So yeah, there's all sorts of confounders, but for sure you're on the track that's yeah. To do that procedure without a high resolution scope, very difficult. And that scope we had was very high resolution, but it's also not newest generation. So Fujifilm will come with a new generation very soon, and they would admit, I'm sure, that is their latest generation. It's not the latest generation of technology, because Olympus have just updated theirs, and Fuji will, I think, next year update their imaging platform to be to the new generation, and I look forward very much to using it. Where should you start a POEM procedure? I think this is also very interesting. Is there some data for that? We talked about the 2 and the 5 o'clock orientation. There are studies that publish the 11, the 12, the 3, the 1.5 maybe. But actually, most people talk about the 1 and the 5. This is not relevant. This is interesting. So when you're coming down here, this is the reason why it's very difficult to go as we showed in the posterior approach. The anterior approach is much easier because it just comes down the lesser curve. The sling fibers are also here, but it actually can be cutting the sling fibers is very useful for the patient. Sometimes when a patient doesn't get a result, I have a few patients who haven't had a result, who have had a result with posterior, and I think that may be because at that time I was able to cut through the sling fibers. I think one word on endoflip, just a quick word, is that it is this functional luminal imaging probe. Depends how long it is. There's two types. One has got 16 electrodes. One has got 10, I think, less anyway. It allows you to do measurements in a space like a sphincter. It's great at measuring sphincters. It measures how much they open because that is distensibility index. It looks like this when you use it. It looks like it's from the 1970s, and the Jetsons should just come out on their scooters or whatever, on their UFOs, and be in the background. It is going to be updated, I'm told, quite soon. Endoflip 2.0, or maybe 2.0 exists, maybe 3.0. Anyway, this is the hourglass appearance of the GOJ. This part doesn't distend, the other does. This distensibility is very low, under 2. The GOJ is too much. Anyway, beyond the concept of this, and this presentation on GIEQs Online. This is not really something we really need to get into now. We didn't really talk about adverse events, what potentially can they be and what to do about them. I think you have mucosal injury. We showed it today. What is the rate? In my practice, not 4.8%, but today it's 1 in 3, so it's higher than that. Esophageal perforation, I guess that means that you leave a mucosal injury or you don't detect it and you don't close it. This is for sure not common, but a big problem if you do have it. Major bleeding is, I've never had major bleeding after a POEM procedure, but it is described in the literature. I think you need to be meticulous about your hemostasis. And okay, it can happen to anyone, but not if you are meticulous, and you're going to get a rate much lower than that, I would hope. When subcutaneous emphysema is pretty common, and it has no impact really, unless you've got air on, then it's not ideal. Pneumothorax, I've had how many pneumothorax? Yeah, I had that one patient who had air on, they had a pneumothorax. Apart from that, I've had one pneumothorax during POEM, I think. Probably due to CO2 pressures. Pneumomediastinum.
It's CO2 pressures or high ventilation?
That's what I mean, high ventilation pressures, often, because maybe because you didn't recognize a capnoperitoneum, maybe you didn't deal with it. It's not usually due to nicking the pleura, but it can be. And you can be well out of plane, and I'm sure you can nick the pleura doing a POEM. So this is another thing that could happen. Pleural effusion, yeah, I have seen this. Yeah.
I saw some endoscopists are using endoflip during the procedure to guide their myotomy. What's your opinion on that?
That's great. I would love to do it. Well, I'd love to do it, but I can't afford it because it's in Belgium. It's not paid back by the influence, so it's very expensive for the patient. It's something like 400 euros, more than 400. So for me, it's not an acceptable cost to add to the procedure. Certainly, we can't pay for the hospital. That means you have to charge to the patient. And yeah, I think the benefit was the benefit that you scientifically, one, that you know that you cut it, and 2, that you have a reference for when you come back if the patient has a problem, has a recurrence or symptoms that you can check. The flip side of that is that you have good visualization. I've taught you lots of things today about how to see if you have cut through the lower esophageal sphincter. I think it's got a bigger role, if I may offer that. It's got a bigger role in deciding in the difficult grey cases before you do. We talked about that today already. One interesting study to show is this one. This is the New England Journal study. This one, yeah. So 2019, surgery versus endoscopy, helomotomy versus POEM. And to all extents and purposes, they're the same. POEM is actually potentially more successful in clinical success of 2 years. It's otherwise not very interesting, apart from to look at the reflux. And the reflux in the POEM group, higher than the henomotomy group at 2 years. Pretty similar. If you talk about the grades of reflux, so we look at serious reflux, rates very low in both groups. That's important. Procedure time, quicker for PONE, apparently. Hospitalization, lower for PONE. And this is very interesting. Even in this article, hospitalization of 2.9 days on median for PONE. I mean, yeah, I think ours is 1.3 or something.